Hello, Dr. David McFadden here again from the Dental Implant Center in Dallas, Texas. Welcome back. I've got another video to show you today, or more of an educational video. And I want to talk today about why and how dental implant treatments fail. There's 4 different ways that I've come up with to explain the failures in implant dentistry. Biological, we're going to go through these one at a time. I'll try to go quickly because it's really boring, but I know many of you are interested in this topic. As much as we are, and we always are trying to figure out if an implant fails, why did it fail? If a treatment fails, which I can't honestly think of an implant treatment failure that we've had here in maybe forever. And I think that comes back to planning and execution. But we've got environmental factors, and I'm sure that many of you are bored by this. Anybody who smokes know that it's a risk for everything in life. Not taking care of your teeth is a risk. Diet always plays in ways that we don't even know about yet, I'm sure. Now, letter D is a big problem in implant dentistry. Those of you who clench and grind, we virtually have no way of stopping you from doing that. And the cause of it is usually genetic. It is a situation that parents, many of you parents out there, can hear your children grinding their baby teeth through the bedroom walls. So bruxism is one of those things that's passed on with our DNA. It's one of the bad things that's passed on with some of the good things, unfortunately. And we believe that more than half the population grinds their teeth. And I've noticed recently, and this is just an aside, but I've noticed, I'm old now, but occasionally I get to be around young people, and I've noticed that more young people have flat teeth from grinding than I've ever noticed before. So I think there's also a medication component to this. Certain medications must make people grind their teeth more than we did when I was a child or generations before me. So maybe another, on a public interest note, if you're noticing your children, their canine teeth, the sharp teeth on the sides, if you're noticing those teeth are getting flat, those teeth should have sharp points on them. And if you're noticing that your children's teeth, or your grandkids, or whoever, noticing their teeth are getting flatter or they are less visible, consider taking them to a dentist and getting at least a mouth guard. And we don't know some of the interactions, the autoimmune patients, we don't know all the details about that yet. But I believe this is a pretty comprehensive list about the ways things can go wrong from an environmental standpoint. So we know mechanically that there's negative outcomes that happen mechanically. Most of the time that our implant treatment failures happen because of poor surgical outcomes. The treatment wasn't planned. Well, let's back up. The diagnosis was incorrect, the treatment plan was incorrect, and the surgical execution had a bad outcome. We also can have prosthetic errors, and we can have laboratory errors. When I say laboratory, though, I'm really blaming the dentist for those too, because we don't have to accept everything that comes back from the lab. There's a lot of pressure on us to accept a product from a lab, even if it's inferior. So let's talk about local infection. I'll go through these as quickly as I can. You know I'm not a short presentation type of guy, but I'll do my best. Infections at the tip of the root. If those are not diagnosed by the dentist doing the implant, that can cause failure. Sometimes there's infections there that we can't see radiographically. Sometimes we can't even feel them clinically. But I'm sure I've had a few implants in my career fail because I didn't catch this. We can see it on this x-ray as well, where we call them periapical radiolucencies, but they're root tip infections from a dying nerve. And we can also diagnose bone loss from periodontal disease on most x-rays. Sometimes it takes a CT scan to look at a different angle or a different slice of the tooth to actually be able to see a pretty big infection. One this size would certainly show up on a small x-ray as well, but there's smaller ones that we don't see on the other x-rays that we can diagnose on the CT scan. Generalized infection, like I just mentioned, periodontal disease. We've got patients who are missing anywhere from 5% of their bone to 100% of their bone. Teeth like this, those are areas where we have to be careful at what point we place implants, if we can at all. But if we get ahead of ourselves and we start placing implants in areas with a high bacterial count, those implants can fail. And this is more of the clinical presentation of a person with periodontal disease. You've heard the phrase long in the tooth. Well, this is where it comes from. When people's teeth get longer, that it's a sign of aging, but it's also an indicator of periodontal disease. The proper term for this is a long clinical crown. We do now know that dental cements can contaminate implant sites and cause implant failure. So we don't do cemented implant restorations anymore and haven't for about 15 years. These are some slides I've accumulated along the way. They're not my cases, but clearly there were other problems with this implant, not just cement contamination, but I do a lecture when I talk to dental audiences about hydraulic pressure and Pascal's law. Is we seat crowns with a lot of pressure. You've probably had a crown where the doctor asked you to bite on a stick or a cotton roll is almost as hard as you could. Well, whatever that bite force is, 140 pounds per square inch, it's transmitted into the cement, and that can tear the attachments around that implant and even get down between the bone and the implant. This is called a giant cell granuloma, and I've seen these just often enough to know that in these cemented cases, when the cement is deep around the implant, the neck of the implant, or even between the implant and the bone, this is a very common response that the body goes through to try to protect itself from an infection. Systemic disease, uncontrolled diabetes is one of our big contraindicators to implant treatment. And again, we're learning more. Every year we're learning more about the connection between systemic health and dental implant treatment. But the good news is that dental implants work a very high percent of the time, in the high 90s from a success rate standpoint, on most every patient. So we do have some other minor things. The diabetics, people who have had radiation treatment in and around the oral cavity. It decreases the vascularity in the bones, especially the lower jaw. And so do bisphosphonates, the anti-osteoporosis drugs. They decrease the vascularity in the jaw bones, especially the lower jaw. And this topic wouldn't be complete. There's many other things that we could add to this list that we currently know about, and many that we don't. And then we also have the comorbidities, smoking and diabetes, smoking and radiation treatment. It all compounds the chances of success for dental implants. So we'll just move forward from there. And finally, the unknown. We actually can never tell a patient. Patients are very eager to know why an implant might have failed. And there's so many reasons, but we simply can't pinpoint it in most cases. And my best guess is that there was some contaminant in the extraction site when we placed the implant. But that really doesn't explain why immediate implants, meaning those that are done right after extractions, versus implants in virgin bone, have about the same success rate. So there's a lot of unknowns here. I don't know if we'll ever figure out exactly why any particular implant failed. So let's talk about strong bite bruxism. I have had a handful of patients over the years who have such tremendous bite force and are so actively grinding at night in their sleep that I've seen implant failures because of that. And here is one of our patients. I've followed this very nice woman for over 20 years after completion of her first set of dental implants. And when you look in her mouth, it is literally ravaged by the effects of grinding and clenching. And you start to see, signs of it. And our only way to combat this is to ask the patient to wear a nighttime guard. And if they find themselves grinding during the day, we can make a daytime guard also. All that really does is protect the teeth, though, because the guard is still going to allow for the transmission of the bite force through the guard into the restorations. So most of the time, 99% of the time, we get away with treating grinders without a problem. Usually it's just a broken component or something happens to the prosthesis that is an adverse effect of grinding. But every once in a while we believe that the forces of grinding have caused the implants to lose bone or to fail. More commonly, we have prostheses that don't fit. So there is a very specific protocol, and there are very specific techniques to assure that the final restoration fits on the implants passively. Meaning that as we tighten the screws of the prosthesis into the implant or into the abutment of the implant, that there is no warpage. We're not pulling this prosthesis all the way down on top of the implant with the tightness of the screw. So when prostheses don't fit passively, you can tighten them enough usually to even get the titanium to deform or the zirconia to deform enough to make it look like it's closed on the radiograph or make it look like it's closed on the clinical presentation. But what we do when we inherit a case here that hasn't gone well, and we fix a lot of very bad outcome implant patients here, the first thing we do is we follow that protocol to get a model of the teeth that is as close as exact to the mouth as we can get it. So again, I won't go through the protocol, but there are certain steps that all good implant doctors should take to make sure that this is as close to the mouth as you can get it, and then this prosthesis fits on that perfectly. Even without screws, there's no movement of the prosthesis, there's no rocking of the prosthesis, and you don't have to tighten the screw to get that gap to close. So that's the way we identify prostheses that don't fit properly. So this is where the other side of the prosthesis is screwed down all the way. It can't go any further, and this side is still off the platform of the implant. So we know this is a non-passive prosthesis. And just another view of the same thing. Usually a non-passive prosthesis affects the prosthesis. I'm sure in some cases the implants are adversely affected by an ill-fitting prosthesis, but more often you have a problem where the implant prosthesis breaks, or you have screw breakage or abutment breakage. Something in the prosthetic side, on the prosthetic side, fails because of the misfit. But I would guess, and I think my partners would agree, I would guess that in the normal pool of patients being treated out there today, that at some level, close to half of the prostheses don't fit the implants the way they should. And again, because the protocol wasn't followed, speed was the goal rather than accuracy. So we can also, like I said earlier, we can have implants fail, and we can have implant screws fail, abutments fail, the prosthesis fails. But on this category, here's a patient where an implant was placed on a molar on a patient who was a grinder, probably wasn't adjusted properly, and the implant itself fractured. So I want to introduce you to this term that we learn as first-year dental students. Iatrogenic outcomes. And what that word means is, the actual definition is illness caused by medical examination or treatment, or in our case, dental examination or treatment. I don't think you're going to have any iatrogenic results from an examination, but I think they're talking about invasive tests when they do invasive radiography or radiology, for example. But anyway, it's a doctor-induced problem that you wouldn't have had otherwise. So this comes in many forms, like I said earlier. There's a lot that happens surgically. The number one reason that implant treatments are either compromised or fail is because of surgical iatrogenic treatment. Here's an example. Not going to tell you that these implants would have been completely covered by tissue had they been done well, although almost all of ours are. This particular doctor was trying to do a treatment that he had seen at a lecture or that he didn't completely understand. So the implants are angled, but they're also out of alignment, if you will. So I would call this a surgical failure or a surgical compromise. And another one, this is a standard all-on-4 treatment where they take away mass quantities of bone, and I've got about 100 videos out there about that. We'll provide links to some of those. But they remove the bone, the tissues follow, the implants get put too far outside the jawbone, and you start to have exposure of the implants. So this again is another, what I consider to be a surgical failure or an iatrogenic outcome. Can be surgical and prosthetic, meaning that you, even if the surgeon does a poor job, a good prosthodontist can usually do a good job on bad implants. But in many of our all-on-4 centers, you get a bad surgical outcome and a bad prosthetic outcome also. So there can be a combined culprits. Here's another one. I mean, this to me is just a toxic train wreck. Everything that could have gone wrong with this patient did. So surgically, you can see he actually has pus around this implant. They took away so much of his bone and put the implant so far forward in the gums that they're now all exposed. They made him zirconium teeth that were so white you need sunglasses to look at this slide. They didn't separate the teeth. It looks like a unitooth all the way around. And then almost immediately the prosthesis became uncemented from his cylinders. And he had to start going to the pharmacy to get dental cement to re-cement this once a day or every other day. So in the all-on-4 world that's available to you, they still consider this a reasonably good outcome. And again, it's beauty's in the eye of the beholder, but I don't know any of you out there that would look at this case and believe that it was a reasonably good outcome. So the implants fail some of the time, but there's a saying about the worst placed implants are those that always succeed. Meaning that, you know, we'd love to be able to easily remove a bad implant or a badly placed implant, but they're very hard to get out of the bone, especially in the lower jaw. So it is always easier if they will fail on their own. That gives us a compromised restart at least. There's a lot of prosthetic compromises and iatrogenically induced outcomes because of the prosthodontic steps. We're talking about prostheses that are supposed to fit within a few microns. And you cannot get fits like that if you don't follow the proper protocol of proper impressions, proper verification, and proper fabrication of the prosthesis. So here's a case that looks really good, and you may have seen this in my gallery. This is one of the best all-on-4 cases I've ever seen. And by the way, it doesn't matter if it's all-on-4, all-on-6, all-on-8, or all-on-X. It's the same protocol. All you're getting is 2 or 4 more implants with the same exact protocol that involves bone reduction and angled implants. But this is one of the better cases. It looks better anyway. But when you take the prosthesis off, it is completely and totally uncleansable. So this is what I would call an iatrogenically introduced compromise that was at the prosthetic level. Same thing on the lower. And I didn't think to take this picture until I had already wiped about 70% of the junk out of the prosthesis. But so this is what every all-on-4 office would call a wildly successful outcome. But at the end of the day, it's not, because the patient can't clean it, the tissues stay irritated, and imagine the patient's breath that's walking around with food and plaque all the time under their prosthesis. And then finally, laboratory, and it's not really the laboratory's fault. Dentists are notorious for wanting things fast and cheap. And when those are your two demands from your laboratory, you're going to get fast and cheap and wrong. Unfortunately, the wrong comes along with the first two. So contours from the lab are notoriously wrong for self-cleaning, for cleansability. And sometimes they put the teeth in the wrong position. We've got this very fit young woman who came in with an arch the size of Steve Harvey's. It just doesn't look right on her, and you can't probably appreciate that from this picture, but we see a lot of teeth that are selected incorrectly, teeth that are the wrong, too bright usually, and you've all seen them. I know that this audience that's listening to this lecture has done a lot of research. You've seen the teeth I'm talking about where it doesn't match the patient. That's a laboratory and a dental error. Then even in 2024, we see cases that were finished in the last 10 years with decades-old technology. And sure enough, I mean, these things fail quickly, and they're very expensive to fabricate. So many of you out there are considering doing this one time and can afford to do it one time. So imagine the disappointment in a patient like this where she had surgical compromises from day one. She had prosthetic compromises, and her teeth literally broke off of the prosthesis. This probably happened to her within the first 4 years of getting it. So she probably spent, I'm going to say, $25,000 to $35,000, and now she's back to this point in 4 years. It's not fair. It's not fair to the patient. So in closing, I'm going to make this statement. Some implant doctors would consider it controversial, but it's truth. The vast majority of implant treatment failures are dentist introduced. They're iatrogenic. That the case wasn't diagnosed properly, it wasn't planned properly, it wasn't executed properly surgically and prosthetically. So anyway, that's what I wanted you to know about implant treatment failures. Thank you so much.